helpful comments this morning. I'm Cindy Kane, I'm from UCLA, and I'm working with Neil, who you've heard from quite a bit already, to think about the organizational responses to the End-of-Life Option Act and to understand at the aggregate level how different healthcare organizations are trying to provide the best care possible in the context of this new legal option. And so what we wanted to do today is to bring together representatives from 5 different major health systems and have them talk about their experience. So I've asked them to talk a little bit about their experience with the Act so far, including patient requests, their experience of creating a policy and what that policy looks like, and then to talk about the different people who are involved once a patient makes a request, whether they are a system that is participating or a system that is not participating, who's involved in helping to meet the needs of those patients. And then finally to talk about one thing that they're really proud of and one thing that remains a challenge for their system. So I hope this will be a helpful complement to the conversation this morning that really will help us to get to work on these types of issues. So thank you, panelists.
Hi, I'm Ann Coscarelli, and I'm a psychologist. Are there any other psychologists in the room? One. Okay. The reason I was asking, because I think my particular profession in my being up here to talk about UCLA policy is significant. And I think that's particularly significant in light of some of the conversation that we've just had. And that is because I think that our policy was built around the idea of looking at individual needs and psychological and psychosocial issues, and I think that that's an important piece in this. And so I wanted to rewrite my talk about 4 times today as I was sitting listening to the comments, and somebody advised me yesterday, don't do that, just do what you planned. And I'm going to try and do that. And I need to do it quickly, I know. So I want to start out with, so we have a policy, and our policy has all kinds of components to it. And there was a whole workforce of over 50 people represented by many different professions who are involved in it. But I think one of the things that came out of it, and there's probably just a few of these that I'm going to touch on, was the engaging a designated clinical consultant. And when I say clinical consultant, I'm not talking about a navigator. I'm not talking about someone who's advocating for the act. I'm talking about somebody who is actually consulting with patients, families, the medical team, and the healthcare system. And I think that that's important and unique. And so the people that serve in the roles of that clinical consultant tend to be, because the act is often used with oncology patients, they're members of my team, which is part of the SIMSMAN UCLA Center for Integrative Oncology for the oncology patients. And 3 of us are psychologists. And then we will have 4 other oncology social workers, and then some additional psychologists and social workers who are part of other teams representing some of the other areas. And, you know, the goal was not to choose the role of the mental health specialist, which is really looking at just capacity, which is what Dr. Strauss talked about yesterday, but really taking a much broader perspective. And I know that I need to do this really quickly, but I wanted to give you a little bit of a sense of what it is that we do, because from the very outset, I think that one of the things that we talked about in our first grand rounds was that this is an opportunity, and it is an opportunity to have conversations and to really look at and do better end-of-life care. And I think that depending on where your bias is in the room, I think that that's probably something that most people, whether you're for the act or you're against the act, would probably come down in favor of that good end-of-life care is an important piece of that. And I think that that was a heavy consideration in the development of this role. And so we do a psychological intake. We look at mental health history, suicidality. We look at family and support relationships and the need for resources. We talk about prognostic awareness with patients, disease status, symptoms, those kinds of things. We look at goals of care. We talk to people about those. And I think that one of the things that I took away from the panel yesterday when the families talked about it was the individual issues that come up for patients and families. And I think this takes an individual approach, And I think it's something that we need to pay attention to the particular needs of that individual. And I think that's part of what we've been doing. We talk about acceptable and unacceptable quality of life. And if you've been in this field at all, and most of you have been, we know that that's something that shifts. Like hope, it shifts. Many things shift in this process. It's not a stagnant process. And I think the goal is really to be able to be part of that shifting process with patients and to engage early with patients in this. We also know from Oregon that more people talk about it than actually do it. If you look at 1 out of every 5 will talk to their family members, 1 in 50 will talk to their physicians about it, but the numbers who actually do it are much less. So that's the opportunity here, is to engage in conversation, and I think that's what we've built our policy around. Now, we also do things like we educate people about the laws, and we talk to them about eligibility, and we help them to understand, we hope to understand their meaning of the aid in dying medication. I need to talk faster. We discuss safety of medication. So we do those other kinds of things that are associated with this. But the important part is helping patients through this process of the fact that they are dying. And I think that that's one of the things that we would agree on, is that, first of all of us are going to die in this room, and that all of our patients most likely are in the process of dying, because those are the patients that we're talking about. But we also provide that support to the family support system, and then on top of that, so we also do that with family members, and so that's an important piece. So we don't look at just the individual, we're looking at that family and community and support system in which they're living with as well. And then the last thing is we really worked hard on the kinds of educational materials, and I brought a couple of packets with me, but we spent a lot of time developing, this is what a packet looks like. It's pretty thick, it's a lot. But the idea is that the packet is the guide by which we're talking from, and that we've written a lot of educational materials for patients. There's a lot of things in this that maybe, that I don't think are in the law, that go beyond the implementation issues, but really about good end-of-life care, which is, how do you want to die? Who do you want with you? What kind of process do you want around that? And many of the patients we engage with are not ingesting the drug. In fact, many of the patients that we're actually engaging with are choosing to leave the drug at the pharmacy, because what they're looking for is an insurance policy. Not everyone has the intention to use this, and most even who go through the process don't have that intention. And I think that when we do a good job in this, then I think that we have that capacity. I talked a little bit yesterday about working with the medical team. That's also a very big part of what we do in terms of helping physicians not only to comply with the law, but also just in terms of conversation, also in terms of the pharmacy itself. And then we also work within the healthcare system. So we want regulatory to happen well, but that isn't the primary goal. It isn't just about crossing off the T's and dotting the I's about whether we followed the regulations. It's about the kind of human healing caring, I think, that's provided to patients at end of life. And yes, this is a small segment of the population, and should we be doing this with everyone? I think we should. We should be doing this with everyone who we can engage in those kinds of dialogues. And I just want to be careful that we don't get too tunnel vision about it. And my time is up, so I'm not going to be able to answer any of the following questions that you asked me to do, Cindy.
Hi, well, the slides are coming up. I'll introduce myself. I'm Melissa Stern. Can you hear me? Okay. And I'm with Kaiser Permanente of Northern California, where I have responsibility actually for advanced care planning and palliative care. And then when this law came into effect, I was asked to take a lead in developing a program with a whole team of people. I say that because I just want to respond a little bit to the discussion we had before I get into this, which is, if we were to convene a group such as Sarah, who's Sarah? Sarah suggested, about palliative care, about advanced care planning, we'd be more than eager to join in that work, to talk about the work we've done over the last several years with advanced care planning and specialty palliative care. but I was asked to talk about our system around end of life. And so I want to say that we started, once the law was taken into effect, Kaiser Permanente took a position of studied neutrality on the law. And for us, that meant that if the law was passed and signed into law, we would implement as our colleagues in Oregon and Washington had done before us. So we convened a work group, and I think in the spirit of this discussion, that work group set about, the steering committee set as our North Star the notion that no patient in Kaiser Permanente, Northern California, would avail themselves of this option due to lack of access to high-quality specialty palliative care or hospice services. And I can't tell you how many times the steering committee and the work groups came back to that notion as we did our work to say, is what we are designing in service of this idea? And does it meet that threshold for us? So we also did a lot to learn about the law, about the Oregon experience, and about the patient perspective. And this is Elizabeth Wallner and her son Nathaniel. And some of you may be familiar with them because Elizabeth was featured on that 60 Minutes piece a couple of years ago. And we were introduced to her. It turned out she was one of our patients. And we learned a lot from her about what patients are looking for and what they're asking for. And I think Elizabeth, too, served as a touchstone for us as we went about our work. We did bring a pretty extensive steering committee together, and that represented people from medical ethics and from oncology and hospice and palliative care and adult and family medicine and pharmacy and legal. And so we really had a big tent approach to how we were going to both craft our policy and design our operational systems. As you see, there was about 9 work groups who were tasked with the various details, including member education and physician education. And then we were asked to speak about the key roles. And so in Kaiser Permanente, there are sort of 3 key roles I want to talk about. We do have what we call patient coordinators. They are different, certainly, than the consultants Anne mentions. And in part, that's because we didn't want our coordinators to take the role of providing all of the consultation and emotional support and psychosocial support for our patients. We really wanted that to be provided in the context of specialty palliative care or hospice care. So the coordinators are there to shepherd the patient and the physicians both through the process to make sure that everyone is familiar with the requirements of the law and the specifics, but also the resources that are available. And so we hired coordinators specifically for this role. We trained them, and they are regional employees. They work throughout our region. And then the other thing that we did was we recruited physician mentors at each of our medical centers, and those were people who would be opting into the law, who wanted to become really knowledgeable about the law and about our processes and about the full provision of end-of-life care at Kaiser Permanente. And those people were brought together right after the law took effect for a one-day training that was done with Tony Bach that really was about how to take a request as a beginning of a conversation and how to have the great conversation skills that are required to get at people's underlying goals and values with respect to the end of life. And so they then were able to mentor other physicians who might have some of the ambivalence that was talked about yesterday about participating because they didn't know quite how to do it. And so the mentors are available to those physicians. We have local leadership teams at each of our medical centers who are comprised of physician leaders, administrative leaders on both the medical group and health plan side to provide oversight and to really work very quickly to ascertain what things are working and which are not. And then we have a regional leadership team. I'm, in fact, joined by Dr. David Conant, who's our medical director, and Ann Gordon, who's our program manager. And we meet both together weekly, and we meet with the local teams monthly so that we are identifying challenges and working quickly to address them. We were asked about volumes and about numbers, and we, recognizing the sensitive nature of this, and I think to the point of people who are talking about data, the lack of agreed upon denominators, and potential misunderstandings, we're not going to share our data, although, of course, we share it with the state. What I would say is we came into this making some projections based on the Oregon experience about numbers of people we anticipated would inquire, would receive prescriptions, and would ingest. And by and large, the numbers have been within those ranges, at the upper end of those ranges, but inquiries more than doubled what we anticipated. But those inquiries fell off quite a bit, sort of as Anne was saying. we were asked about what we might want to do differently or what the opportunities are. And I think there are two, although we were asked about one, so I apologize, Cindy, two key things. The first is that there's opportunity for better integration and communication with hospice, with the teams that are in the patient's homes. And that includes our internal hospice, where we're definitely seeing some great practices emerge, and we have a sense of where we want to go, but also external hospice agencies, because at times we do send patients to external hospice agencies. We're talking to Leah about the opportunities that exist there, and I think that's some work for us. In terms of what, I wanted to end on what we are proud of, because that seems like a better place to end. There's three things. In terms of learning opportunities, the other notion here is I think about disenfranchised grief and bereavement, that people I think whose loved ones choose to die in this manner may not feel, for some of the reasons we're addressing in the room, comfortable bringing that up and being public about that. And so their ability to avail themselves of grief and bereavement groups may be hindered. And so we want to make sure we have avenues for them to address their grief. Finally, we're proud of our patient coordinators. They're remarkable, extraordinary people. They provide really exceptional, devoted care at all hours of the day and night. We are proud of the support that we've provided to our physicians and our clinicians. As I mentioned, there's the training. We have built debriefs into our workflow. So there's debriefs that in a team manner that are facilitated often by psychologists or by chaplains for each of the cases. We have often had these brought to short center rounds, and so we think we're providing quite a bit of support for the clinicians, because as mentioned yesterday, people do need support throughout this. And then I think what we're most proud of is that in Kaiser Permanente, Northern California, 100% of the patients who were found eligible for the end-of-life option, not necessarily who went all the way through, were either enrolled in hospice services, received palliative care consultations, or both. And I think that tells us that the true north that we set out for ourselves, that we are keeping in that direction. Thank you.
Thank you. Good morning. My name is Ruchika Mishra, and I'm with the ethics program of Sutter Health. So Sutter Health as an organization decided to opt in right at the get-go. And we were very sensitive to the fact that, at the same time that we were trying to promote this opting in of, we wanted to make sure that the patients had the right to access providers who were able to write the prescription, but at the same time, we also wanted to promote the right of physicians and other providers within our system who did not want to participate. So really trying to be sensitive to the needs of our patients, but at the same time, also the needs of our providers who did not want to opt into the process. I wanted to address the questions that Cindy had basically asked us to. So we're not going to be sharing our specific data, but at the same time, I can speak to what our overall experience has been with regard to prescriptions. On an average, we've received about 6 formal requests for prescriptions on a monthly basis. Overall, many of our patients have taken those medications and have died as a result of it. We've not really had any major hiccups in the process, so it has been pretty smooth and pretty coordinated overall as an experience for us as a system. And what did we do in terms of policies? So right at the get-go, I think it was April or March, we obviously, decided that we were going to be participating. And what that meant was that, we needed to have a robust system put in place before the date was actually effective for the law. And so, just like most other healthcare systems, we had, 3 months to make sure that we were all prepared and that we did have a process in place to respond to the needs of both physicians, other clinicians, as well as our patients. So we had about 10 work groups that ranged from education to policy to the different settings in which the law would be implemented. And we really wanted to cover the different aspects of the law once it was supposed to be implemented and put into place within our own system. So speaking about policies, we have one system-wide policy, and the policy essentially tries to cover the different aspects of care or service lines that Sutter Health provides. So for instance, the one policy covers acute care setting. It covers what the processes are going to be in the ambulatory care. And then also the third is the home health. So home health for us covers hospice as well as our advanced illness management program and other services that are provided within the home setting. So those are the three different aspects of the policy that we try to address. And each section of the policy, essentially as it pertains to the care setting, it goes into the details of how to respond to requests for EOLOA information, requests for the medication itself, requests to administer the medication, what would be done, in the emergency setting if the patient took the medication and was brought in by their family. How were we actually going to address as a system non-participating providers, also requests for presence at the bedside by patients for physicians or other clinical staff to be there, as well as how to address requests for preparation by clinicians. If the patient basically was not really able to prepare the medication, then as we all know, it is legal for somebody else to assist them with the preparation, but not with the administration. So, how would those specific requests be addressed in each of our different care settings? So those were the different aspects of the policy that we tried to cover. With respect to who is involved in these EOLOA requests, so of course, as it is understandable, it would be the patient's primary care team that is participating. But apart from that, we have at a system-wide level, we have an EOLOA system-wide lead, and that is the person who basically connects the patient with these clinicians. If, for instance, the patient's attending physician is not participating, then, there is this lead person who basically connects the patient with the other resources within Sutter. We also have an EHR navigator, so we actually have a tool built within Epic that walks the providers, mainly the attending physician and the consulting physician, through the process. And the forms are also pulled up as they go through the process. So there is somebody who actually holds the physicians and the clinicians' hands as they are being walked through the process. We also have, at the system-wide level, we also have an advisory team. We also have what's called a physician subject matter team, and these might not be clinicians who are participating themselves, but at the same time, they are clinicians who are very well versed with the law, and they're really there to provide that physician expertise with regard to the requirements of the law. If there are any ethical issues that arise during the, either during the request process or even with a patient who is inquiring about this particular law or how it impacts them as a patient, then in that situation, we do also have our ethics team that helps the physicians, clinicians, patients, and families through navigating these ethical issues. So what are we most proud of? I think that as a system, so far, we've been really proud of the fact that it has been a seamless, coordinated approach and a process for us so far with the implementation of the law, as well as integrating these requests into the workflow of patient care for our system. But also at the same time, the commitment that the system has made to patients who want to avail of their legal right to exercise this end-of-life option. The system has made it very clear to the patients that if their own physician is not participating, then the system will try to connect them, or will attempt to connect them with a participating provider within the system. Of course, that also kind of brings us to a challenge, which is that we don't have enough providers who are participating. So that's, that kind of takes us into the challenge aspect of the implementation of the law within the system. But there are also some other challenges. For instance, what we've also found is that patients and family members, they've been very frustrated and sometimes also angry when they've not been able to find participating providers. And time and again, what we've heard from them is that, patients in these situations really feel like they're being left to suffer. And so there are patients who've talked about how, there is this law that gives them this legal option, but at the same time, there's no law that requires someone to provide it to them. So those sort of expressions of frustration have been shared with us. But the other thing that, we've also experienced as a system with regard to a challenge is really trying to fill in the gaps when it comes to knowledge, whether it is with regard to physicians, clinicians, or even patients and their families regarding the eligibility, the criteria for being a part of the law, when it comes to the processes, the skills that are required, just like many other panelists have talked about, as well as the psychological aspects, the emotional aspects of the experience that patients, families, as well as our physicians, and I don't want to leave that out, as well as the physicians who participate in the law, even though they have made this, decision to participate, it doesn't mean that it is, easy for anybody. It is hard for everybody who is involved in the implementation aspect of the law. So thank you.
Thanks. Hi, my name is Glenn Komatsu. I'm the Regional Chief Medical Officer at Providence, California. Just a sentence about Providence. We are one of the largest Catholic health systems, not-for-profit, in the country. And we have over 50 medical centers ranging from Alaska and all down the West Coast, Washington, Oregon, Montana, California. Now with our joining St. Joseph's down into Texas and New Mexico. So I will go through the questions that Cindy gave us. The requests for prescriptions, we do have those. I'm speaking primarily from our hospice perspective because we have one of the largest not-for-profit hospices in Los Angeles with an average daily census of still not that big, but about 250. But we've had less than 10 requests for prescriptions in the first year. What policies did your system develop? So we did develop a physician-assisted suicide policy. Unfortunately, we had to call it physician-assisted suicide because that's what our colleagues in Washington and Oregon developed, and they kind of insisted that we keep it consistent throughout the region, which I didn't really agree with, but you heard the talking points, the major talking points yesterday from Russell. I think the policy is one thing. The talking points I was asked to develop because we really wanted to have a common language, especially for the physicians that were having these conversations with patients both in palliative care and hospice, but also for our intake staff who are getting cold calls from the community asking, do you participate? And the intake staff, the admission staff, and as well as our liaisons. So the other thing that was mentioned earlier by Catherine, I think, we did take this opportunity to develop a more robust palliative sedation policy. And I think that is an important element in any good hospice and palliative care program. So that is something that we developed, and we also did extensive education with the staff, both on the End-of-Life Option Act as well as the palliative sedation policy. Next question was, who is involved with end-of-life requests? So the interdisciplinary teams in both hospice and palliative care, as you would imagine, with the medical directors and physicians taking the lead in patient and family communication. What is the thing that you're most proud of? So we have had pretty exceptional leadership in California in hospice and palliative care, led by Terry Warren, who's a member of the coalition and a member of the planning committee. Russell, you met yesterday, Russell Kiefer, and Ira Byock joined us in 2014. So we are committed to his vision, and our vision, it's a shared vision really of transforming the culture of medicine. So the End of Life Option Act was a sidelight, and obviously an important sidelight, but not our primary focus. So we have really done some concrete things to transform the culture of medicine throughout the continuum of healthcare. And so just to give you some examples, concrete examples, IRA's Institute, Providence Institute for Human Caring, is a very sophisticated team of clinicians, data analysts, marketing communications, community liaison people, along with project managers who work collaboratively with the hospice teams and the palliative care teams, using them as change agents in the clinical settings to roll out what we think are some of the best vetted tools available in the country system-wide. So examples of that would be the Serious Illness Conversation Guide, which was developed by Susan Block and Atul Gawande at Ariadne Labs at Harvard. So that's now formatted in our electronic medical record system. We've done training throughout our region to help clinicians of all disciplines have those serious illness conversations. We have a system-wide contract with Angelo Volandes for use of his advanced care planning videos to also aid us in the discussion and education of patients and families. We have a system-wide contract with the CAPC, the Center for Advancement for Palliative Care, to use their training videos to train clinicians, again, of all disciplines across the system. And we also have a contract with StoryCorps to use that program to record the narratives of not just patients and families, but also clinicians, caregivers, and administrators. So we've renamed it Hear Me Now. So, and lastly, the Institute has been working very hard on quality metrics and quality scorecards that we can then replicate across the system that would measure not just the numbers of palliative care consults and the types of patients that we're seeing, but also the quality of the measures, like how many cancer patients are dying with stage 4 and stage 3 disease in the ICUs. So the one thing that remains a challenge is doing all of this, quite honestly. So it's one thing to set this as a goal, it's another thing to actually operationalize that. So that is definitely a work in progress. But we feel like this modest goal of transforming healthcare is the right one. Thank you.
My name is Nathan Fairman. I'm a palliative care doc and also a psychiatrist. I mentioned that yesterday. Which one of those I choose to disclose kind of depends on the setting I'm in. And I'm the medical director of the End of Life Option Act program at UC Davis. And I wanted to actually start with something that I'm particularly proud of with our implementation, and that is that I think we've been fairly successful in positioning involvement in the End of Life Option Act as an option of last resort. And the evidence for that, along the lines of what Melissa shared, is that all of our qualified patients have been enrolled in hospice. And then in addition, along the way in developing our policy, there were a number of discussions with senior leadership around the importance of expanding access to specialist palliative care. And about 4 months ago, the health system made a major investment in expanding access to specialist palliative care, and I don't think that's coincidental. So just as a helpful way of framing that, with the tip of the hat to Anne and her psychologist colleagues, there's a kind of parallel process where we're teaching our physicians to essentially to leverage an inquiry about the End of Life Option Act into a broader discussion about end of life care. That same process is happening organizationally, we focus so much on the End-of-Life Option Act that we've been effective, I think, in leveraging that interest into material support for expanding palliative care. So that's the achievement that I'm proud of. In terms of our process itself, it's actually quite similar to the process that Ann shared with you at UCLA. Our process requires the involvement of a clinical patient navigator, which is an LCSW. I actually have 2 LCSWs that are hired full-time for this role in our process. And then also we use the oncology social workers in the cancer center space. And they are expected to do a broad initial psychosocial assessment for every patient who makes a formal request. And that information is used by the attending physician and the consulting physician to help them understand, kind of from a total pain perspective, what sorts of things are driving the patient's interest in the end-of-life option. And then I mentioned too, we've also created space for the role of a medical director, and I have an accountability function to our chief medical officer, and am essentially responsible for most of the educational efforts that we do, and provide a doc-to-doc consulting function as well. And then the last thing I'll do is just shift and list a couple of challenges that we've faced. So the first one actually echoes the challenge at Sutter, which is how to come up with an effective process for transfers when patients make a request to a non-participating physician. And how to do that in a way that is efficient, but also tries to honor the importance of having some kind of meaningful relationship with a provider. That's been particularly challenging. The second has been cultivating physician participation in the cancer center space. We have a comprehensive cancer center and very low rates of physician participation among the oncologists. Third has been, and this has been a theme throughout the 2 days, has been coming up with some strategies to provide support to participating clinicians and staff. Even the most, not sure if this is the right word, but strident supporters of this option find it challenging and difficult to engage in this process with patients. And there are some unique needs around support. So there's a couple of ways we've looked at that. We too have short center rounds and have focused on the End-of-Life Option Act in those rounds. We've started doing a monthly in-service with our hospice program, which I lead. And then we also have a quarterly dinner for physician participants, in which we talk about some of the challenges those providers have faced in doing this. And then the last thing, and this is actually the very specific thing that Cindy asked me to comment on, was we have had a few cases in which patients who are not really UC Davis patients have nonetheless presented to our system and asked for assistance with this law. And our policy is quite explicit in saying that UC Davis doesn't accept transfers for the sole purpose of participating in the End-of-Life Option Act. But each case, actually this is just an example of a larger thing that happens, is that we thought we had this really nice, neat policy that would sort of account for all of the bumps that we might encounter, which hasn't been true. And so each case has interrogated the policy in unique ways. And so we've had 3 or 4 cases now where folks don't really have a long-going relationship with our institution, but for one way or another, they've showed up and asked us to engage with them in the End-of-Life Option Act. And in some cases, we've done that, and in other cases, we haven't. It's forced our work group to think very carefully about the areas in which we can allow some flexibility for our policy. I'd be happy to talk in more detail about that or other aspects of this too. So thank you.
Thank you very much to all the panelists. Certainly some commonalities and experiences, but some different kinds of ways of solving some of those issues. So we'll open it up for questions.
Ira Bayak. Deep respect to the panel. This was very informative. Thank you all. I have a sensitive question. In the history of nowadays, hospice and palliative care seems like in this room it's motherhood and apple pie. We all accept it. We all think it's important. Should be universally available. Was not always the case. And in fact, while inpatient palliative care is now routinely accepted, many of us are still working hard in our health systems to advance it to the outpatient, office-based, home-based telehealth environment. Part of that is the business case for that. And we in palliative care have been very effective in driving the expansion of palliative care, leading with quality, but also acknowledging that there's a financial impact, a valuable financial impact to the hospitals and health systems. My question, and it is sensitive, have either any of you looked at the financial impact of people who choose the End-of-Life Options Act on your organization or institution or the insurers? And if not, would you be open to doing that financial impact analyses, and would you know, if the funding was there, would you be willing to take this on in a spirit of kind of transparency for all of us within the field and the public?
So I'll start. I appreciate you being here and your perspective and your questions. I would say two things. One, this may be hard to believe, but at this point in Kaiser Permanente, Northern California, all but one of our medical centers has outpatient clinics 5 days a week now, so very different than even 3 years ago. We've had a tremendous growth, probably much like Nathan mentioned.
You've taken a lot of our fellows, actually.
We've taken a lot of your fellows and a lot of the Stanford folks' fellows. Yes, we have been. You have to populate your program with that very small pool of people. But what I think will be hard to believe is actually we don't build business cases for our outpatient palliative care clinics. We've made a decision as you know, the largest medical group in the nation, that palliative care is a medical specialty and that we just have to provide it. So there's no business case for that. So we don't do those analyses, believe it or not. In terms of whether we would be willing to do it here, it's not for me to decide. I would have to take it to our executive leaders. I suspect we probably aren't, but I'm happy to ask.
I have just a quick comment, sort of alongside your question, Ira, is that one of the questions that's been raised in our work group has been, this is a concrete way to look at this, has been whether or not involvement in the End-of-Life Option Act is associated with earlier hospice enrollment. We suspect that it may be, because when patients are making a request, as I said, essentially the initial conversation with them takes a step back and looks broadly at the patient's readiness for end-of-life care. And we suspect that they're probably getting enrolled in hospice earlier. So from a resource utilization standpoint, that would be one avenue to look at.
Thank you.
Hi, Paula Goodman-Cruz, Kaiser, Southern California. For the record, our program is very similar to Northern Cal. I do have a question, though, that has been a challenge in our organization. For patients who are under the hospice benefit, and in large part, most of our patients are under the hospice benefit who avail themselves to the end-of-life option. If there's no hospice physician that's willing to take on this role, certainly we'll try to find another physician, either a hospice doc, but if there's no hospice doctor, for instance, a primary care physician, our leadership has been very clear that that physician who's taking over needs to provide the full array of hospice services, meaning participating, in good faith with, the meetings, that level of care. And so, unfortunately, but maybe, we're trying to respect the regulations. We've been disenrolling these patients from hospice for the time being, and then readmitting them to hospice. And it's during the time period where it's usually that 30-day period where they're, trying to meet the needs of the End-of-Life Option Act. So I hope that makes sense, and I'm wondering if your institutions have been, what your interpretation is of the hospice regulations in terms of, during that period of hospice doctor, is not willing to participate.
I can speak to that.
So within our system, we actually do have a lot of our hospice physicians who are not really willing to participate. And what we've decided as a system to do is that those physicians will continue as the hospice physician, and we'll have, another physician from within the system who will act as the EOLOA attending physician for that particular purpose. So we've kind of tried to keep those two roles very distinct, and even in a situation where the hospice physician wants to act as the EOLOA attending physician, we've tried to keep that separate in the sense that they would have to relinquish their role as the hospice medical director or the hospice physician in that hospice setting. Does that answer your question?
Yeah, I guess it does, but I think it comes to the issue of what's the definition of an attending physician under the hospice benefit. And ideally, it would be nice if you had co-attendings, but that's really not how our organization has interpreted those regulations. We'll, of course, re-enroll the patient back, but this also creates a lot of distress, moral distress on the part of the providers, fractured care for that patient. But we're trying to stay in compliance. So I don't know what your organizations are doing and how you've interpreted those regs.
I don't know that I can speak specifically to that, but I think it's relevant in that many of the patients that we're seeing are actually engaging the process while they're still getting treatment. And so they are, so they're not enrolled in hospice because they're still engaged in treatment. But they may be going through that process. At the point at which they make the decision to go off treatment, then they enroll in hospice. And there's a very strong push to get people who no longer want to continue treatment, obviously, to go on hospice. So I think that's been certainly a factor for us in what we've been seeing. And then also we've sometimes seen that patients who have made the decision to go on hospice are sometimes patients who also make a decision to abandon the process, because there's a certain number of patients that we get started with the End of Life Option Act, at least in terms of we're having these various discussions, and as part of that discussion, and that could be they abandon it before an attending ever signs a form, or it could be that somewhere even later on in the process, that process is abandoned, and there's a significant number of people that fall out of the process, which I think goes back to my original comment that it's more about kind of the conversations and the whole process of end-of-life care than it is just about getting the medication.
We have a question right over here, and then we'll come right back to you. Thanks.
I just wanted to make a plea, if I may. Again, Lonnie Schabel from Bay Area End of Life Options. While all of this is happening, with the patients are kind of deciding how to find consultants who will be in all that, and Rashika, you and I have worked on this quite significantly, time passes. Sometimes a lot of time passes. And I would just make a plea that remember, we lose patients in the 15-day window for two reasons. One, the 15-day window. Two, how long it takes for that first verbal request to happen. And so just to remind you all that if somebody, for example, in Rashika, in your system, makes a request from the patient's point of view and says, I would like to make this request, that does not initiate the 15-day window. It has to be made to the attending physician for the End of Life Option Act. And so these patients are sort of hanging on during that time. And at some point in time, and I think we probably agree to this, it's appropriate to refer out of your system if it's taking too long to get through the system, because losing time is losing health. Maybe I'm corrupting that time is heart expression or time is brain expression. But in our case, really, there's some case to be made for expedition. And if your system is not geared up to not say, well, next week you'll have an appointment with so-and-so and you'll talk to him about it, and the following week you'll have an appointment with so-and-so and you'll talk to her about it, these are patients who are very close to getting to be on their way to dying, and they don't get their End of Life Option Act request because of these delays quite frequently. And not that that's bad. Still, hospice does a great job with aiding people in dying. There's no question aiding people in dying is not only medications that I would use, it's all the ways that we aid people in dying. And the problem, though, is that they're not getting their type of aid in dying that they have requested. And so I'm just putting in sort of a plea for, if your system is sluggish, don't have the patient suffer through that system for too long, because what it often means is that they're going to die during, I get called finally, and they're at the edge of that 15-day window, and then we lose them in that window. The sooner, if you are making outside referrals to places like me and places like Bob down in San Diego, make those referrals fairly quickly. Make up your minds earlier whether your system is going to work or not. Does that make sense? It's kind of,
Great,
this
thank
is
you.
sometimes needing to be expedited.
Carl?
I just wanted to go back to what Paula said, and maybe somebody else in the room knows too, because this law has been around, in Oregon for 20 years and whatnot. But I know some hospices are very strict, and will say, because of the federal restriction on any funding, basically sign them off, sign them back on. Other hospices are a little bit more lenient. They find workarounds. They'll say, right, the doctor's not working in that capacity, or they're doing it kind of pro bono or something like that. But I'm just wondering what the experience has been in Oregon over all those years and how they, deal with that sort of conflict. Anyone know?
I'll just say for our hospice, we don't sign patients on and off. They can pursue the End of Life Option Act while they're on our hospice with our support,
Yeah.
but not participation.
Yeah.
Can we get a microphone to Clarissa, please?
My name's Evan Pulvers. I'm a resident doctor in family practice at Contra Costa County. And one question that I had is sort of especially for UC Davis and Kaiser and UCLA, where it's hard to find and cultivate physician participation, but you guys also have a broader social mission of physician education, how you guys are working to sort of leverage that teaching mission into expanding access for providers within your systems, if that was part of the conversation around this.
Yeah, just to make sure I understand, was it a question about the teaching mission and leveraging, developing physician participation?
Yeah.
I can just speak to a couple of sort of educational strategies we've used. So Davis has both a School of Medicine and a School of Nursing, and last year I was asked to help develop a module in the doctoring course in the School of Medicine. So last year and then this year it will be repeated. There's a 4-hour unit on aid in dying. It's a case-based small group discussion with third-year medical students and a cohort of students in the graduate nursing school. We also have done, I mentioned some outreach to physician groups, but we also have done a similar kind of training at the GME level with internal medicine, family medicine, neurology. Haven't yet done psychiatry, but we've also done some fellowship training programs as well, including the HEMONC program. So as much we're able with respect to the resources we have, we've tried to hit the groups that are the learning groups that are most likely to find themselves in a position of having discussions like this.
Great, thank you. We have time for one last question. Looks like we're fixing the microphone.
Hi. I just wanted to make sure that the comment about the 15 days doesn't go unaddressed. The reason why 15 days is in there is because it's a process, and people evolve, and people change their minds, and people, in fact, the majority of people change their minds, and 15 days is an extremely short period of time to implement a plan to relieve someone's suffering, and 15 days is an arbitrary number, one that was pulled out of a hat. It might take 16 days, it might take 20, it might take 6 months for someone to work through that process, and we don't need to be in a hurry. I just want to make sure that doesn't go unchallenged.
Thank you. Let's all thank all of the panelists. Really helpful information. We'll have each of the panelists introduce themselves and then launch into the assignment for the day.
My name is Laura Kaler, and I'm clinical director at Hospice by the Bay. And Hospice by the Bay is the oldest hospice in California. We serve 6 Bay Area counties, including pediatrics. And we have an average daily census of between 500 and 550 patients. We are also, as of the last 2 years, an affiliate of UCSF, which we're very proud of. And we, closer, can you hear me now? Okay. The minute Jerry Brown signed the law, we got together a group of people. We're 4 thinkers, and we have a pretty big standing in the community, so we really wanted to be thoughtful about how we approach this, and knowing that there'd be requests from the press. So we gathered together and really started out conservatively, which I'm sure many agencies did, because we just wanted to wait and see what kind of patients came forward, how did the community respond, what was the just the flavor of it. So we are an opt-in agency. We looked really closely at our values and came up with protocols that fit with how we see ourselves. And basically what we have come to is that all of our clinicians are able to have these in-depth conversations with patients. The inquiries must start with the patient. It is not something that we would bring up, and that's an issue that we talk about a lot. So if a patient doesn't know about End-of-Life Option Act, we do not offer that to them. I imagine that might change over time. Our physicians do not prescribe, and we put a lot of meetings together and talked a lot about that, but they are able to be consultings. And what we've changed over time is that as soon as we know patients pursuing End-of-Life Option Act, our physician, our hospice physician, outreaches to the attending right away, so that we are actually really involved, so that we know what meds are being used, so we can prepare staff. We also do allow our staff to be present when patients take the medication, but not to be in the room when the medication is actually being ingested. And that is really to make sure that we're not around anything that goes against the letter of the law. We don't want to put our staff in compromising positions. We also do have an extensive debriefing with the involved staff within a week of the ingestion, and the purpose of that is just to gather information. We just want to know who these patients are, what meds they're taking, how our policy is impacting them, and we also want to know how it impacts staff, and I'll speak a little bit more about that. That's been a big focus of ours. So in the first 15 months, we've had 30 patients that we know of who've taken aid in dying medications. Probably a few others, although I spoke to one woman yesterday, they kind of think they know about patients who took meds and didn't tell them. We don't have that flavor. So there's been 30 patients and approximately 270 inquiries. Now for us, an inquiry is anything from, have you heard about the law, to actually pursuing it. So that data doesn't mean so much. Our physicians have consulted on 26 cases, some of which the patients took the meds and others where they have not. And our staff have been present at half of the patient ingestions. So that's just a little bit of a flavor of who we are and what we've done so far. You know, one thing I'll say about our policy is that we, in the course of the debriefings and other things, Survey Monkeys, other things we've done, is we've changed our practice as we're learning what's impacting staff, and I'm sure that will be continuing. So at first, everything was focused on the social worker. We realized everyone's having these conversations, so let's train everyone to have these conversations. At first, the We had not really trained the nurses on what you might face when you're actually in the home when the patient takes the meds. Now the doctor's super involved. The doctor's like on a bat phone at the other end. When staff is in the home, there's a doctor designated to communicate with the staff while the deaths are occurring. The deaths have gone beautifully, I'm happy to say, so there hasn't been a lot of need for doctor involvement while they happen. To my questions. So, all team members are involved. Every social worker, every clinician has been trained to have these conversations. We have not had clinicians who have asked to opt out at this point in time. That is in place, and they're supported in doing that. But mainly I'll just say, our staff have been kind of more supportive of the law, and I really want neutrality. We spend a lot of time on neutrality, what neutrality means. We also now so all staff can be involved. We actually have one clinician who does the bereavement follow-up, and we're doing that. We have separate bereavement follow-up. That's a change in our policy because we really see these people as potentially isolated and might not have a lot of people to talk to. So we do outreach, and we've gotten incredible feedback. They want to talk. They'll spend an hour. I have to do boundaries here, but they'll spend an hour talking about the impact of the act on their family members. And again, it's amazing how positive, like the women who spoke yesterday, how positive they've felt about their loved one having the option of taking aid in dying drugs. It's been almost universally positive. The thing I'm most proud of, that we're really proud of, is I'll just say I've been a hospice clinician for 25 years, and although there's been a lot of change sort of at the federal level, in terms of clinical practice, this is the biggest change in clinical practice in my entire time of doing hospice. And what we're trying to hold is, our patients are the patients who are going to take the meds. The Bay Area is, I suspect, going to have high numbers of patients who take advantage of the law. So I want to help staff normalize it, incorporate it into their practice. And on the other hand, it's a big deal. And this is a completely different kind of death for those of us who've been doing this for a long time. So we're really trying to balance both of those things, and I think we're doing a pretty good job. We did a survey of staff who've participated, and 75% response rate, and 91% said they felt very prepared and supported by their team and the agency. So that's something I feel really good about. The challenges are, of course, resources. We are not the prescribing. We have a wonderful relationship with Lonnie that has been super helpful, and our patients have been really grateful for your involvement, Lonnie, I just want to say. But the resources aren't out there. The process is cumbersome, so we hear that a lot. And I think the other thing that's internally a challenge that we'll be grappling with is how to support patients take advantage of this law and still maintain our neutrality. There still is, as people mentioned yesterday, that public perception, it's changed, of you come to hospice and you die, you get morphine and you die. And there's still some fear about this act kind of feeding that. So that's one of our internal struggles, is how to be supportive, how to advocate in a way that maintains our neutrality. Thank you.
Hi, how's everybody? I would just want to start by acknowledging the courage it takes to do this work, regardless of where you are in your beliefs and your practice. It takes courage to work with those who are talking about the end of their life, considering the end of their life, or actually in the end of their life. So I just want to acknowledge that for everybody here today, and thank you for being courageous enough to be here. My name is Connie Polmano. I am the Director of Social Workers, Chaplains, and the Pediatric Hospice at Hines Hospice in Fresno, California. We have been in practice in Fresno, Merced, and Madera counties for 35 years. We have a census of about 250 patients, 30 of which are children. Our board was very proactive, much as Laura had said. Our board was proactive in, when this became a law, they rolled up their sleeves and started having the hard discussion of how does this participation, or how does this law affect a very mission-minded hospice? And our position is that Hines has and always will believe that the end of life is natural. The dying process is a natural human event that we are honored to support. We also believe in the piece of the hospice philosophy that seeks to neither hasten nor postpone death. We also believe at Hines Hospice that it is our duty to never abandon our patients or their families at the end of life. And so Hines Hospice does not actively participate in the End-of-Life Option Act. However, our policy does afford for education and support, and that is education in the law. So our social workers, when there is a request, our social workers do go to the families and utilize this opportunity to have goals of care conversations, to have end-of-life conversations, to employ our hospice physician to talk about, let's talk about what's behind the ask. And I hope that we're all doing that. I was very encouraged to hear that as a common theme and thread in many of the conversations we've had. We also employ the interdisciplinary team, which includes our spiritual care providers, our nurses, our home health aides, in surrounding the patient and their family to support what this might look like for them. What we do is we continue with our usual hospice care for our patients. Our hospice care runs parallel to their legal right to pursue this option. And we do, however, acknowledge that this is a conversation between the patient and their primary physician. What I think is going well is our ability to support our staff. We call what we call a core IDG, which involves senior leadership, director leadership, and the interdisciplinary team affected. We talk about their ethical position. We do allow staff to opt out of care of patients who are pursuing this so that we can assign others, and we do that in a non-judgmental way. We also educate our staff. Our board approved our policy in March. I began educating our staff in April and May, and I do on a quarterly basis educate all new staff as to the law, as to Hines Hospice policies and procedure, and answer their very difficult questions around this. And one thing that remains a challenge, I think for me, so my background is in spiritual care and counseling. I feel a little bit of an enigma. I'm not seeing a whole lot of spiritual caregivers in the room. Oh, hi. Thank you. We're all spiritual. Yes, we are. Thank you. But by profession, that specialized focus on the existential needs at the end of life, I feel like what's a challenge is I feel often in our healthcare system, we have forgotten about total pain. I want to thank Doctor for talking about total pain. We can't forget about that. We can't forget about end of life is largely existential and more existential. Dame Cicely Saunders, that was the question. She asked her patient, are you in pain? But the pain wasn't physical. We can't forget that. And while I feel that in many agencies we really try to do this well, I still think as a healthcare community, I think there's a lot of work to do. And if we channeled some of the energy that we have and passion that we have around talking about the End-of-Life Option Act also into resources, which I think are sorely lacking for total pain and alternate therapies and outside of Western medicine, I think we might see some movement in other areas as well. Thank you.
Good morning. My name is Ann Hughes, and you can see I'm an advanced practice nurse in palliative care at Laguna Honda Hospital. And before I begin, I just want to make a few disclosures or disclaimers. I'm not sure which. First, even though my representation on the panel is as a representative of long-term care, I don't want to pretend that the experience at Laguna Honda which is a publicly owned and operated facility, which is blessed with having a physician on site 24 hours a day, and a large staff is representative of all long-term care facilities in the state. We are publicly owned and operated. We're part of the San Francisco Department of Public Health. We're part of their integrated delivery system, which you'll see in the next slide. But I will say we provide acute rehab care, post-acute care, as well as long-term care. And just one other personal disclosure. Before I began working at long-term care and at Laguna Honda, I have to admit my own implicit bias about working in long-term care and what long-term care was about. And I share it with many of my colleagues that were at Laguna. We never expected to have a career in this facility. And I think all of the cultural taboos about nursing homes, about long-term care, about aging and disability, the language of warehousing, all the other kinds of things, even the support study used life in a nursing home as one of the negative outcomes. I am somebody who's also been affected by all of that. So let me just tell you, having had many, many years of Catholic education, I'm afraid I followed the rules and still working on relieving that. But anyway, I think it's too late now. So what policies did we develop? Well, as I mentioned before, we're part of the San Francisco Health Network. It's our integrated delivery system in the Department of Public Health. So the department itself, the network itself, developed a policy about End-of-Life Options Act. It very much aligned with the state law. It was developed and approved by clinicians and executives, and then endorsed by the San Francisco Health Commission, which is our governing body. Laguna Honda is the only part of the San Francisco Health Network, which includes Zuckerberg, San Francisco General, which includes a home health program, Health at Home. It includes community clinics and public health centers, a vast array of health services. We're the only part of the network that felt the need to develop a setting-specific policy. And that was because End-of-Life Options Act assumed people that would exercise this right had a home and had caregivers. And when you work in a safety net setting, you know not to make that assumption. You know you can't count that there'll be lots of people loving and available to support someone. You can't assume someone has a home. So we did develop our own policy. Our end-of-life option task force included representatives, as you can see from the slides, palliative care, ethics, the deputy city attorney, risk management and quality management, our pharmacist, and I want to acknowledge my friend and colleague in the back row, the chair of our ethics committee, Dr. Grace Stammen, who is also a member of this group. So what were some of the considerations in our policy? I hope yeah, good. Well, first of all, we acknowledge that skilled nursing home residents are, just by virtue of being in a facility, are a vulnerable population subject to coercion. We're mindful of that. One of the things that came up from our pharmacists right away was the need to secure and account for controlled substances if they were dispensed in advance for use at an unknown time. We talked about having double lock rooms. What would happen with persons with memory problems who were wandering in the rooms? I mean, it was really going to be a nightmare. We had conscientious objections from some of our staff, primarily our nursing staff, who had very strong religious and moral objections to the practice. We needed to honor that. We were also concerned as an institution that we would be asked to admit people who had no skilled nursing need but had no home, and the law is clear not to take the drugs in public, for the sole purpose of ingesting, and we had no relationship with them. And that was really problematic. And we also made a decision in our policy to limit the practice to our palliative care unit. We have a 60-bed palliative care unit at Laguna Honda. Who's involved in the request? You can see, of course, the resident, the physician and the care team, if the resident is living on a unit, one of our other 12 units. I don't know if I mentioned, but we're a 780-bed facility, so we have quite a few residents. The palliative care team is very much involved. If the resident chooses to pursue the option, they're relocated, and the palliative care physician assumes the role of attending, and we have a second Laguna Honda physician who serves as consulting. Ethics consultation is available if there's any questions about coercion, about just about the process. We learned from colleagues in Seattle, because when we were looking at this law, we went to the Oregon data. We saw that some of the people that had acted on the law actually lived in long-term care or assisted living. I contacted the Department of Public Health in Oregon. Can you give me the names and phone numbers so I can contact these facilities? And what we got instead, fortunately from another colleague, was a wonderful facility in Seattle, Bailey Boucher. They had been through this process. They were just incredibly generous in sharing their procedure. And so they actually had, and you see the next bullet, number 6, we have a conference with the resident, with their family or whomever is available. We really try to elicit what their hopes and concerns are for the process. And you know, I think of, I've been a nurse a long time, and remember when we talked in the beginning of the birthing movement, of having birthing plans. Well, I sort of think of our conference is going to have a leaving or exiting plan of who do you want to be there, what should the environment be like, and of course, quality management oversees compliance with paperwork. What we're most proud of, well, we're not aware of any other facility that has developed this policy yet, but there may be, and we may have somebody right in the audience. One of the things we did, the department, when the planning group at the network began, they surveyed physicians and pharmacists and mental health specialists about their willingness to be involved. We became painfully aware that if this happens in an inpatient setting, there are other providers that are affected. So we surveyed porters, we surveyed social workers, we surveyed volunteers, we surveyed nursing assistants, LVNs, RNs, chaplains. And I think we've developed a procedure and the policies in the back, and I can talk about that later. I know I'm almost out of time. This also gave us the impetus for creating a very special room, a suite that we will not use simply for end-of-life, those exercising this right, but also for anyone in our facility. We learned in the course of this analysis, we had 35 residents on our palliative care unit in the previous year that died in a double room. We thought, this is not okay. So this suite now we have created is going to actually meet that need. So I think we're going to extend beyond this very narrow use. And I'll just leave my slide up for what our challenges, and I think that's probably it. Thank you very much.
Thank you and good morning. I'm kind of the oddball on the panel today because I'm not representing a health system. I'm Heather Harrison. I'm with the California Assisted Living Association. We represent assisted living providers, all licensed residential care facilities for the elderly who provide 24-hour care and supervision for seniors who can't live alone but don't need the level of care that's provided in a nursing home. We've, as an association, we've been working since, really prior to this law taking effect to help educate our members on the new law, the requirements, and the steps that they'll want to go through to set up their own policies. And that's been our focus, is to making sure that assisted living providers have the information they need to set clear policies, make sure that their staff and their residents and families understand what those are. We haven't had a lot of experience yet. We've periodically reached out to our members to get a sense of what the experience has been in their communities with residents who have elected to participate in the End of Life Options Act. And there has been some. but not a lot yet. So we are continuing to work to gather information so that we can learn, what works, what doesn't, what can we do to help shore up this process and make sure that the assisted living providers and their residents and families and staff have what they need to have this be a successful process. The first decision that an assisted living provider would make is what's their role going to be? Are they going to participate or not? Assisted living is not a healthcare provider. This is a resident's home, and they have a right to exercise their option under this law. The assisted living provider has the ability to decide what their role is going to be, whether they're going to participate or not. Many are deciding not to participate. They want to respect their residents and the choice that resident makes, but they're not going to be involved in the process. They won't be storing the medications. They won't be present during ingestion. But again, this is the resident's home, and they have the right to exercise this option. Many assisted living providers are asking residents and making this part of their policies up front. They're asking residents, should you choose to elect this option, please let us know. The law doesn't require that people disclose this, but it's helpful for the assisted living staff to know if this is going on so that they can provide that support to that resident, to other residents, to staff, so they can make sure that medications, that they're aware of how that medication is going to be secured. Anne mentioned a resident with memory issues wandering into somebody else's room. We want to make sure that there is a plan, that the family and the resident has a plan to keep that medicine locked or off-site until it's being used, not to direct how things are done, but so that we can be informed to avoid any outcomes that are undesirable. We don't want any unnecessary or avoidable or counterproductive 911 calls. So having that information up front is helpful. And I mentioned the medication storage is an issue. One of the challenges and the concerns going forward is the impact on our staff. One of the providers who I spoke with who had a resident go through this process right after the law took effect, so it was very early on. It was really hard on his staff. And this was a resident who was on hospice, and the hospice did a fabulous job. It was a very different experience for other deaths in the community. So the support from hospice was tremendous and very appreciated. We're continuing to work with the Department of Social Services as questions come up. Guidance has been very case by case, but making sure that we continue to get information out to providers on how this works. While I was sitting here this morning in the back during the break, I checked my email. I had an email from somebody. I have some questions about the End of Life Options Act, and what does the Department of Social Services expect us to do? And I'm like, we need to continue to get this information out to people, because those of you in this room who focus on this so much every day, that it's not the experience out in the broader community throughout the state. And so it was a good reminder to me to keep that information out there. We continue to address it at our conferences and through our workshops. One of the things that I'm most proud of is for our membership in the conversations we've had internally and at our conferences and educational programs is the degree of consideration that our members are giving to this process, and the whole broader discussion that this has opened up, not just specific to the End of Life Options Act, which is the core point of a lot of the education we've been doing recently, but the broader issue of end-of-life care and support and the relationship with their residents and families and hospice. Assisted living providers, our members take this seriously and really want to be there to support their, really everyone in those communities, from the residents to their families and to the staff. We're we're eager to learn more as there is more experience with the End of Life Option Act, so that we can learn from that and help support our members in doing what they need to do as this evolves in California. Thank you.
Thank you. My name's Dr. Bob Uslander, and I'm from San Diego. I'm actually from Chicago. I'm a Cubs fan. Any other Cubs fan in the room? A room, like 100 people, and there's no other Cubs fans? Wow. So I appreciate being given the opportunity to come up and speak and share my model and perspective. Question, aside from Lonnie and Thalia, I imagine, has anybody else in the room been with a patient who has taken the medication that's been prescribed and been with them when they died? Cool, good. So interestingly, I have a small practice. Your census is 500 to 600. My average daily census is 15 to 20 patients. My practice is very unique in that it's a private model of essentially a palliative and end-of-life care. And I was an ER doctor for 22 years, and I saw a lot of death. I saw a lot of bad deaths and a lot of challenging situations. 10 years into my career, I had the opportunity to help a friend of mine who was 32 die of melanoma. And that was my first exposure to hospice, and I saw a different way of caring for people and a different way of people dying. And it left a mark with me. And about 10 years later, I was in transition, looking at what I was going to be doing. Emergency medicine was no longer, it just didn't feel right for me. It was getting way too stressful and challenging. And I was looking at a transition, and I had started a house call practice in a home care company and in the past, and I had an epiphany. I had a download that said I was here to help people die. And the next day, I just randomly started a conversation with a woman who turned out to be a hospice nurse, and the company she was working for was starting a palliative care program. And I, over the course of a few months, ended up becoming the medical director for a developing palliative care program in San Diego. And it's been a couple years in that role. About 6 months after I started that, my mom was diagnosed, had a recurrence of lung cancer from 10 years before, and she had a very rocky several weeks and died. And 8 months later, my father, who was extremely healthy, working with me, running my company, was diagnosed with stage 4 lung cancer and died 4 months later. And he had what I thought to be the gold standard for a death. He had 4 months of really good quality life. He spent 3 weeks traveling with my son through Asia, Thailand and Cambodia and Vietnam, and he came back and died 2 weeks later. And the night before he died, and he wasn't really struggling, he was just declining, and the night before he died, I was with him, and he asked me to give him something to end it, because he was just done. He was a very pragmatic guy. He didn't want to linger, and he said, "Can you just end this?" And I said, "No, I can't do that. That's not legal." And I'm not sure I would anyway. And he said, the last words he said to me were, "You can't have it both ways." And I don't quite know what that meant, but I think I got it. And that was in July of 2015. I started my practice in January, and it's really designed, my practice is designed to help people have the most quality of life they can while they're living through their challenging illnesses. So we have a team of doctors, nurse practitioner, physical therapist, music therapist, acupuncture. And then June 9th, 2016 comes along, and this law comes into effect, and I thought, well, that's a positive thing for people, and I'm assuming most people who are looking for that support will get that support from the current system. And the phone started ringing for people who were looking for support because they weren't getting it elsewhere, many of us have heard about these people who were waiting for the law to pass, and just with bated breath and feeling like their struggle would be over soon, and then they had a new struggle that they were going to be facing, and that's trying to get the support. So I was able to meet with some of these people and find out what they were dealing with, and I just the phone kept ringing, and I kept meeting with people and finding out what their challenges were and their needs were, and I have become, I guess, sort of without planning to, one of the go-to people in Southern California for helping people through this process. So since June of last year, I've had about 75 inquiries, and I've engaged with about 70 of those patients. I've written 57 prescriptions, and 48 of those people have ingested the medication to date, and I've been present with 34 of them. Another 10 are holding on to the medication. And I should say, one of the things that I guess what I'm most proud of is honoring my dad and kind of staying true to my conviction, which is to help people have the best possible quality of life as long as they can, and allowing them to self-determine and have control at a time when it's so critical. The challenges that remain for me are, because it's a private practice and I don't work with insurance, there's a financial constraint. I do have the ability to see patients and take care of them without charging them, which I do. But I have a lot of challenges getting consulting physicians at times to support the patients. Some of the doctors who have been caring for them for years are still uncomfortable. I have been successful in changing attitudes, I think, or at least developing greater understanding about what the role of a consulting physician is. And I think in doing that, in those conversations, I've been able to help people see that this isn't, while it's important to look at all the parameters, it's not so burdensome to support a patient as the consulting physician. And one of the things that I'm really hoping to continue is to elevate the conversation about end of life, because it's not just about aid in dying. It's not just about getting this prescription. There's a lot of people who don't qualify, and they still need a high level of support, and the best possible palliative care in the world isn't going to change the fact that they're 96 years old, bedbound, and struggling every day, waking up wishing that they didn't. So there's a whole lot of additional support that we can be offering. I should say that 9 of the patients that I consulted with who either didn't qualify or didn't want to wait for the 15-day waiting period chose to start VSED, and were able to have a very peaceful and dignified end of life with support through me and the hospice agencies that we've worked with. So thank you.
Thank you to all the panelists. We do have a few minutes for questions, so please raise your hand and we'll send a mic over.
Probably have questions for all of you. But, I wanted to ask Bob, because I struggle with this too. If you're seeing a patient really specifically for aid in dying, and I've seen some of these too, because all their treating physicians have opted out, and I feel like they still have a right to access. But the kind of the letter of the law kind of tries to specify that the prescribing attending physician for aid in dying should be the physician who's already been treating their underlying condition. And I feel like in some cases I really have not. And it seems like in your case, maybe you're really not technically that treating physician. I mean, how do you reconcile that? Because I struggle with it.
So I become their attending physician, and they typically will sign over. If they're on hospice, they'll sign over for me to become their attending physician. Not all the time. There are times when I become their attending physician really specifically for this purpose. And I guess I reconcile it by recognizing that no one else is going to support them. And I get very engaged with them. Part of the model of my practice is that I'm available 24/7. My staff is available 24/7. So I usually and I almost always meet with the patient and family in their homes. And I spend as much time as they need. Sometimes those visits are 2.5 hours. And then there's a lot of conversation that happens in between. I'll have conference calls with their family members, with their children, with their siblings. So I really become an engaged member of their team, working through a lot of the questions and concerns. It's not a transactional relationship. It's a very deep, meaningful relationship, especially when I have an opportunity to be there with them. And you know, their families kind of become my friends in a lot of cases. So I'm not sure if that means I'm not really truly complying, or if I'm just interpreting. But I'd be interested in hearing any other thoughts about that. And again, I would be okay with not having this be part of my practice. That would be my goal.
Great, thank you.
Can I offer just one thought on the legal definition? So I think there's a lot that we need to clarify in the law, but one thought is that outside of participation in the End-of-Life Option Act, if you are treating a patient who refuses care, we've never found that you cease to become the patient's attending physician. So, so I think, you know, we need some more clarity around that point. But I just wanted to point that out, that you're not always actively treating the underlying condition, and that's never been the point of an attending. So I just thought I'd share that.
Thank you. We have one question in the back.
Hi, doctor. Thanks so much for coming. I have a hypothetical question for you. In your practice, what would you do if you got a call from end-stage ALS patient, and you met with the patient and the family, and everything seemed fine, but when you looked through the patient's chart, you saw a note from a nurse or a social worker saying that the patient is really struggling due to the need for around-the-clock skilled care, and that the hospice is not providing that, and that the patient feels that they're too much of a burden on their family. What steps would you take when you saw that note?
Well, I would say that it's difficult to have a pat answer to that, because I would have a conversation. If the patient wanted to engage with me and get me, have a consultation, I would have to spend time with the patient, the family, really exploring what that was referencing. And the ALS patients are a unique, they're challenging in the context of this law. It's very difficult to put a time frame. I do have one of my earlier patients that I saw has ALS and seemed to be declining. So there was evidence of fairly substantial decline over the past several months. And in speaking with their neurologist and the other members of his team, it felt like they would qualify.
Well, sure. I'm talking about someone who's clearly qualified.
Yeah.
They're qualified, and all the reasons seem right.
Okay.
Okay, but you see this note.
Yes.
In the file. What do you do?
That said that the patient is struggling and needs more support.
The patient is struggling due to the need for around-the-clock skilled care, which the hospice is not providing, and the note says that the patient feels that they're being too much of a burden on their family.
I would be working with that patient and family to find the resources they need to provide her with that support.
Thank you.
We have one question over
I'm not under oath.
We have one right here.
Yeah, excuse me. Hi, Lonnie Schabel again. Bob and I have a pretty similar practice, and I wanted to explain this attending physician dilemma, which is that the law uses the term attending physician in a way that is contrary to our common knowledge. It is the attending physician for the End-of-Life Option Act, not the traditional somebody's on the ward and they're the attending, somebody else is a consultant. So we have to almost think backwards about the terms attending and consultant, because according to the attending physician, let me back up for a second. The simple answer that I've been able to come up with is we have a contract with our patients called the Transfer of Care Agreement. Every patient signs it, and what it says is very simply that the patient has their regular doctors who have been their attending physicians. Rule for my practice is that those physicians have declined to respond positively to the patient's request for aid in dying. Therefore, they're no longer selected by the patient as their attending physician for the End-of-Life Option Act because they're not participating. Therefore, they elect me or Bob or any other doctor who wants to do this as the attending physician for the End-of-Life Option Act, which does not preclude them from seeing any of their other doctors. But the attending physician for the End-of-Life Option Act, which is now me, becomes the primary doctor, not the primary doctor responsible for the treatment of their terminal disease, because they've declined treatment of their terminal disease. We become the primary doctor for their end-of-life care, which may or may not include aid in dying. So there's some steps in here, but there's an actual formal transfer of care that says their physicians are not complying with their request. Therefore, they're choosing us to be the aid in dying physicians, if it comes to that. But we are primarily responsible for their terminal care. And again, to emphasize something I may or may not have said before, when I do a consult on a patient, the consult is not titled an aid in dying consultation. The consult is titled Evaluation of Terminal Care. And that may or may not include that, but what we're doing is we're becoming the people who evaluate and continue care for terminal care in a space that's been open to us only by the rejection of their primary physicians of the request the patient has made. We don't come in and get involved at all if the patient's primary care physicians or what was traditionally called attending physicians will participate. We love that. So does that make sense? There's an actual formal transfer of care that I believe needs to be done to comply with the law for us to be the attending physician.
Great, thank you. We have a
Can I
question.
change the
up here.
topic? I just have a question for Ann Hughes, and I want to thank all of the panelists as well. Ann, you represent such a unique kind of perspective in this room, and I'm struck by the fact that the patients at Laguna Honda, that there have been no requests and no completion of using the Act. And I'm wondering if you could read the tea leaves on that a little bit and speak to what might, whether it's a matter of the size of the population who might be eligible, whether it's a function of the things that you have in place for people, and just your thoughts.
Thanks, Laura. I actually, my hunch is, and Barbara may know about this, Barbara was on my dissertation committee. I actually studied the meaning and experience of the urban poor with advanced disease, related specifically to what they thought dignity was over 10 years ago. And it was an extraordinary experience. And one of the things that I really came to learn was the resilience and the fighting to live for people that have not had a lot. So I don't expect that we're going to have many requests. I think, so many of the people that we work with really are fighting for their existence. And to think about, every day is a struggle. Where are they going to sleep at night? Where are they not going to get robbed or raped? So when they come to our facility and they're in a safe environment with housing and food, and so I don't expect that will be a big issue. We do, though, have a 60-bed palliative care unit. We have a physician who's very comfortable in the face of intractable symptoms using palliative sedation. And that intervention has been going on for quite a few years. So I think that's my hunch. We did have somebody who came to Laguna almost probably the week after the law went into effect, and he'd been transferred from our sister hospital from Zuckerberg. And he almost, his opening statement was, "I'm here so you can give me the medicines and make me die." And of course, our network didn't have a policy, we didn't have a policy, and then, unfortunately, this gentleman proved himself to not be eligible because of mental health reasons. So my hunch is, Laura, I don't think we're going to get a lot of requests. But as a safety net provider, a public institution, we had to honor, this is a state law, so we had to make this available. But my hunch is I don't think we're going to get a lot of requests. But we really thought, I think we struggled too, not only with the safety issues about the medications, which our pharmacist was wonderful in telling us, well, you need a double lock system, you need, you have to have accounting, and I think our staff, because a lot of the staff in our facility are very religious, and they do this out of a mission, and they were really frightened. They were assuming we were expecting them to euthanize the residents. And that is, they weren't buying that. Nobody's buying that. So that's my hunch. Yep.
So I wanted to interject a significant level of caution with regard to the attending physician issue. This law has very robust section of definitions in it, and attending physician is very specifically defined as the physician who has primary responsibility for the health care of a requesting patient and treatment of the patient's terminal disease. That's an and, it's not an or. So the physician, in order to qualify as the attending, has to be both. So I would just exercise some caution when reviewing that definition and making sure that the situation is compliant before taking on a patient as the attending physician.
Great, thank you. Can you tell us your name, please?
I'm Alicia Wagner with the California Medical Association.
Great, thank you.
Catherine Forrest. I just want to appreciate the sensitivity to the caregivers in the various settings and the willingness of people to do that education and continuing to do that education so that people have the opportunity to opt out or be supported in their own views. So thank you for that. I wanted to address this issue of attending physician from the point of view of a family doctor. This is the same issue as when we refer to hospice, and it's the same issue when we accept psychiatric medications. And so it is a tender one and a delicate one that we in the front lines and are mostly prescribing manage all the time. And it has never been challenged. It's the same language as in Oregon has not been challenged there. Doesn't mean that it won't be challenged in California, but I just want to acknowledge that difficulty. It comes up all the time in primary care when transition of care is occurring for whatever reason. So thank you for acknowledging that.
Thank you. We have time for one more.
This question's for Connie. One of our challenges with helping patients through navigating the whole process is in cases where they enroll in hospice first and then it turns out that they've enrolled into a hospice that's not participating, this becomes really challenging for the patient and the family. Either they have to disenroll to complete the process or they have to pay out of pocket for at least 3 expensive physician visits back to the cancer center, wherever, and maybe by then have very difficult ability to go in to be seen in the cancer center. So I'm just wondering if that's what you've seen with some of the patients that get on your hospice and pursue this. And also, as we kind of brought up yesterday, do you inform them up front of your opting out when they enroll?
Yes, thank you. So 2 questions. First question, do we inform them? Yes. So at admission, we do let them know that we are a non-participating hospice in the end-of-life option. We do show them, we do a high-level overview of our position and our policy, and we do give them a copy of it to read and ask them, invite them to ask any other questions they might have. As far as our experience, first of all, we've had a very small handful in relationship to our average daily census over the year of patients who have either asked about it or even smaller who have actually ingested. And what we have seen is that patients are coming to our hospice with having already had those conversations with their patients. I can probably count on one hand 2 or 3 patients who, having been on our service, then decided, well, maybe I'll pursue this end-of-life option thing. But most of the patients, and again, it's been a very small percentage, most of the patients who have at minimum requested or asked us, what about this physician suicide thing? Very small percentage have done so after they've been admitted. So for our experience, we haven't really had that. And then the second piece to that is in our area, there's a very small concentration of private physicians who participate. in the different systems that we have available to patients. And Kaiser, we do partner very closely with Kaiser, so the majority of the patients we have had have been Kaiser patients, and they have ample access to physician support, the coordinators, and then in conjunction with our social workers and interdisciplinary team coming alongside and supporting them in their hospice journey. And it's really, it's worked very well, so we haven't really had that challenge with patients so far.
Great, thank you. Let's all thank all the panelists.